Ethmoid bone jam and development. Now, this is probably not something that you expected because you expected at what level of cerebral palsy you have. Okay. My goal before I die is for every parent to have a plan of action. Now, whether or not you want to listen to me, that's a whole nother problem. But I believe that you're educated because you've got children and you need to know how to work with your child's development. I don't care if you think that they're typical or we have a diagnosis of CP. But what happened to your daughter is, and this is something that nobody else is going to catch, is she has an ethmoid jam. Now, that happened during intubation. When you're working on respiratory support, unfortunately, especially when it's that fast, they're whipping the head back and they're intubating the baby. Hi, Katie. Yes, this is for you. And sorry it took so long. Sometimes when the posts are there and then with the videos. Anyway, so when you have an ethmoid jam and that happens, and this is how I know. So when, and I'll show you on my skulls and stuff. So when they're putting the intubation in, and then they put the tubing and it wraps around here, you kind of get this look on the face. Now, I have proportionally, we all have proportion 5 eyes. So the eye width, eye width, eye width, and eye width. So there's 5 eyes across for proportions. So if you look at your daughter, she has a wide nasal bridge, but the nose goes up. Almost like someone did this, you know. So we're here, I have this, now I'm an adult face. But what you're seeing here is more of a wide nasal bridge, right? I don't know why I can move my eyes apart. So the eyes go off, and right now I can't see you. And you have more of this, and this kind of look, and this kind of talk, because the ethmoid jam. Now to explain what this is, now in an infant's skull, right, there's very fine little nasal bones, right? They're just so tiny. And so when you're intubating the child, and I have lots of things on this. When you're intubating the child, they're bringing back the head off the table, and they're I hate to say it, if it's an emergency, they're shoving the tubes down. And then they tape the tubing around the soft tissues of the maxillaries. So then the intermaxillary suture is the suture that comes in between your mouth, right? And you can see this with this guy here. So there is a suture here, right? And so that suture, and again, you see a nice round arch and so forth, but that suture, because there's tubing here, and then they wrap, usually tape around it until you have that. Now, guys, intubation could be just a very small amount or it can be a large amount. If the jam happened, it happened. But this is my biggest argument, is that people don't evaluate a child for movement or a baby for movement. You have major stuff that just happened during hospitalization. You're seeing the effects of birth trauma. You're not seeing the effects of hospitalization. Now, guys, I'm not saying don't intubate your babies. The objective of a hospital is to keep your child alive. When a baby goes home alive, to them it's a successful birth. It doesn't matter if they're on a trach. It doesn't matter if they're on, again, oxygen support, BiPAP, CPAP. It doesn't matter. Your child going home alive is a successful birth. Now, this is an adult skull, but it's a bit smaller. So if you look in here, you will see a little yellow bone going back into the eye socket, right? If I crack this face open, this little yellow bone is actually the size of a walnut, right? And this one has your nasal septum, your vomer, as well as the ethmoid, right? And it's this little walnut that goes into. And what happened is that got jammed. That jam is spreading out the eyes. Now, if you take 2 fingers and pull, you can't see. Your eyes will go blurry. You have to keep your head stable and pull. So this is where you're getting confused because you're going to the eye doctor and they're saying there's nothing wrong with her eyes, acuity-wise, but I can tell you right now that you have issues with the ethmoid jam and her vision for functional vision. So she does not have binocular vision, and she doesn't have convergence. And for anyone to walk down the hallway, I have to be able to have short convergence, just like I'm here right now talking to my phone, but I also need to have long convergence. So I have to look down the hallway and be able to come back to you. Active passive convergence is really important, especially when it starts going into school. My child needs to look at its paper and then look up at the teacher and come back again, right? Active passive convergence. When a child is not walking, right, in going into the 13 months with walking and cruising, right, their eyesight stays very short, just because that's what they're used to. But this is why, too, you're getting this. Because, again, she's got, when she comes down, her vestibular is way off. Now, this is where, again, I'm not here to sell, but cranial work is really high-end. It's different than cranial sacral. It's cranial movements. This is why I started doing the cranial courses, because, again, my son has had total jams in his sinuses because of the Haemophilus influenza. That's why I was blind for 3 years. People don't understand how the nasal movements can affect or have its toll on vision, but also for vestibular stability. So what needs to be done, and again, it's in the cranial courses, and now they're in the optimal course. So, I mean, for $300, you get all these courses, but you get the cranial stuff. It is more advanced. It just is. Cranial sacral is grade 2. I've done cranial sacral. I'm a level 2, but it didn't do with movements. You know, up lever teaches that, you know, your inner physician showed up. I'm sorry, the clients I work on, their inner physician took a holiday and they're not coming back. So you have to working on these facial movements. A simple course is a swallow course, but your objective is any place that you thought that there was tegaderm, and then afterwards cannulation. So it goes up here, and this is where a lot of kiddos that have had the breathing interruption also have speech issues. There's one bone in our body that floats. Well, all our bones, in a sense, float. They're not attached to anything, but the hyoid bone. Now, they're taught in school that the hyoid bone is just to anchor the tongue muscle. But what it is if you look at cannulation, it goes here around the nose and they cinch it right here. So it doesn't, and you'll get these kind of mouth movements. So my swallow course is there to work with all of these kind of things, but you really want to go wherever you felt there was tegaderm. And gentle stuff. It could be while she's sleeping, where she's just in your arms, but you want to work on that midline crossing. Everybody thinks midline is right here, but it's also right here. It's also the zygomatics, your cheekbones. It comes everywhere. And she just didn't have the opportunity to set up those movements. So you're wanting her to walk and go down the hallway and so forth. But when I'm like this, right, and you can do it, go like this and put your arms out and drop the jaw and really try and walk down the hallway. It's not easy. Now, you have compensation skills and comprehension skills. Your daughter doesn't, right? So if it hurts her or it's difficult, she's not going to do it. 1 second. Happy New Year, Kimberly. How are you? I did get your email. I haven't looked at it yet because I've been busy with Graham. But I'm glad I got it. And my abstracts aren't due till end of Jan. Okay, sorry, guys. So Kimberly and I are like bestest friends who never talk until stuff like this. So when you're looking down the hallway and you want your child to walk, now the equipment that they give her to walk, and Kimberly did an excellent presentation at Harvard, and I'll pop it into you, with standards and walkers. And this is where I've got a design in my head, but hey, I need money. But the walkers, you have to push like a horse with a cart, or you're pulling, right? And you're using the hands also on it. It's not part of your body, the walking, you know what I mean? You're working around an apparatus. So she has, again, a directionality, but to actually support the standing and go from there. So honestly, we just need those facial movements. You can see again here my bigger skull. The white bone here is your ethmoid bone. It's really encased into your whole, you can see it all through here, through the nose. that walnut is really integrated into our system. A lot of people go after this sucker here, your sphenoid, because it goes around and so forth. But I'm telling you, if you have an ethmoid jam, that's what you're going after. It is, again, more advanced, but it's possible, because that's why I did everything that I do, because it's possible. Anything that anything that I tell you about is possible. I never present stuff that just can't be done. I'm here to show you, that's the one thing my son taught me, is possibilities over limitations. Anything is possible, but it's going to take some time, and that's where you need to go after. But this is what's throwing her off. Her whole vestibular system is inverted, and we need to bring it forward. I wish they would talk to parents about this when their children are going through this, but that doesn't matter. You need to work with your child and work with that. So, and that's what you need to do. That's your number one priority. And I'll link up the swallow course, or like I said, or the cranial courses in the optimal, that. And I would go there. If you're doing the cranial, because it's in the optimal and you both cranials, do the head course first and then go into the nasal course. The nasal course will talk about the ethmoid jam specifically, but you still need to work on your hand work and your confidence and so forth. I mean, it's a learning curve, but it's doable. Thanks.